I can't tell you how many times I've heard from our chronic pain patients that they have symptoms in some spot and the doctor or therapist they're seeing just never touched them. In this treatment video, you're gonna see my dear friend Guatham, who's 51 years old and also went to my alma mater, Franklin and Marshall College. Go Dips. He's a wonderful man. He's a teacher of Vedanta, which I'm very interested in, is the ancient Indian spiritual knowledge base. And so he always tells me that I'm treating his physical adhesions and he's treating my mental, emotional, spiritual adhesions. And then I laugh because I actually really need it. And he's been having this butt pain for 4 or 5 months, which is not long, but he did have it for 8 years prior. And he did his normal PT thing and it wasn't helping. And in this visit, he had some symptoms in the front of his hip with hip flexion. And so I feel the area and then I chase it down to where he has some lateral thigh symptoms. Palpating and treating his lateral femoral cutaneous nerve at his IT band, because when people have chronic IT band symptoms, it's typically because LFCN is chronically stuck and tight. So you'll want to be able to find out where it's stuck. And then I chase those symptoms to see if the other nerves are adhesed in nearby spots.
Yeah, the left thigh. And the right glute, much better, but activity and standing, again, after a few minutes, you can feel that tingling, so I stop. Like you said, don't irritate it. So.
The left thigh, is that still 65% better or same, or is it any more better since last visit?
I think it's the same. Today was the first time I sat in a cross-legged position and I could go for about 10 minutes without pain, which was good. So I would say what you've been doing is helping it for sure. Both. I could be sitting like this, or I could be even sitting like this. Today, this morning, I was sitting like this. Okay. Yeah.
Let's start with that one, okay? The problem with being an adhesion release methods provider is that most of us are workaholic perfectionists. And Guatham is in his 20th treatment, and he's about 50% better for standing or walking up at 51 years old. And I like to get people better a lot faster than this. He did have this pain really bad from 12 years ago to 4 years ago, and then it was largely resolved 4 years ago. And then it came back about 5 months ago, and it's been a nuisance ever since. So when I talk to my mentors, they usually tell me, Chris, your expectations are too high. We're getting relief. His ranges of motion are getting better. His symptoms are getting better. He's tried a bunch of other stuff, physical therapy again, chiropractic, stretching. The stuff hasn't worked, and he's improving. I often have to calm myself down and just say, Chris, chill out. It's moving in the right direction. He has disc degeneration that's shooting into his glutes on both sides, and he's getting nerve symptoms down to his foot. It's all moving in the right direction. As long as people are making progress, things are going the way that it needs to be, and however long it takes to get somebody better is however long it takes. One finger, what do you feel?
Not much. Maybe one little stretch here.
Full, what do you feel?
Same thing. A little bit of a stretch. Here.
Here.
Here. This is more. Yeah.
2.
1 or 1.5. Yeah. Maybe 2.
Anytime someone points to where their symptoms are, it's a really good habit to check that area to see if there are adhesions there. You could see that he was pointing right near the rectus femoris tendon in the anterior hip. So I typically will check, especially the femoral nerve above and below the inguinal ligament, because it's a very common spot for entrapment spots. But also the femoral nerve will come down along rectus femoris, go underneath rectus femoris, and then the lateral femoral cutaneous nerve will come out from underneath the inguinal ligament and go under the ASIS over rectus femoris. All this stuff can be stuck, so it's pretty easy. It'll take me a few seconds to just check this spot. If you're not checking these spots when people point to stuff, get into the habit, because it's an important habit to have. The butt bothers you walking, the thigh bothers you sitting.
But it's like difficult to say. It's not walking. When this pain is there, like it'll just suddenly come up. Like while I was sitting now driving, not driving, sitting in the passenger seat, comes and then it goes back in here. So
Sitting,
it could be standing. Yeah, sitting, I would say mostly, yes.
What am I looking for? Wherever there's smoke, there's typically a fire. So usually when I'm doing general scans for palpation, I'm looking for smoke. I'm looking for hypertonic, trigger point, contracted tissue. If you can find that, that is caused by a nerve entrapment somewhere typically. So I'm looking for really hypertonic tissue typically, and then where that hypertonic tissue is, there is a nerve that's entrapped somewhere nearby. And where that nerve is actually entrapped will not be hypertonic and contracted or a trigger point. You will be able to have easy access to it. So if you're trying to treat a nerve that you think is entrapped, but it's covered by hypertonic tissue, you're probably in the wrong spot. Find somewhere that you have what we call better access. I found some spots at the lateral femoral cutaneous nerve, lateral to rectus femoris, right where the vastus lateralis lives, just anterior to the TFL-IT band area. So I'm probably going to mark the spot because I believe I'm going to turn him into side posture and then treat him that way. The lateral femoral cutaneous nerve comes out L2, L3, goes here underneath the ligament, and then it comes out underneath the ASIS bone right here, and it goes down the outside of the thigh. So when he's sitting with his leg turned out, this lengthens that whole nerve. So he's been complaining about this for a little while, and I haven't focused on it as a first priority. And usually when we focus on priorities, instead of distracting ourselves, which I do, things get better. So I'm taking my time to palpate this. If you're not into the habit of using body markers to mark spots, it's a really good habit to get into because it will help you really focus on making sure that you're feeling nerves. There's a difference between saying in your mind that you're gonna try to feel a nerve or taking the body marker and writing exactly where that nerve is, because your mind will focus more if you actually have the body marker. And now you might be asking, Chris, he has glute symptoms, why are you treating the lateral femoral cutaneous nerve? In 17, 18 treatment visits, when you're treating chronic sciatica or any type of referred disc pain in the butt, it's really important that you remove all major adhesions from the entire low back and hip region. And I don't think that I had treated the lateral femoral cutaneous nerve previously. So if it's really tight in the anterior thigh, the glutes are going to have to protectively work overtime in order to counter that force. Let's say if he's walking and that trailing leg is behind him. So therefore, all of the stuff needs to be removed over the course of care in order to get somebody the sustained relief they want. Is it still hurting?
Yeah, now, at this point, yes.
Okay.
It's reproducing what I'm talking about.
Over here.
Here.
Yeah.
Here.
Got it.
This over.
Hopefully you notice all of the time that I was spending palpating. You could just guess treating adhesions by just picking a random spot, which I'd done for 5 to 10 years earlier on in my career. But it works a lot better when you spend time palpating and then just treat the bad adhesions, because you'll just be more effective. You'll also notice I changed positions from in front of Guatham to behind him. And the rule of thumb is wherever you have to put your body to generate better tension on the nerve entrapment is where you need to go. Because of what I felt in my thumb, I decided to move behind him instead. The lateral femoral cutaneous nerve runs down the IT band area and VL area like train tracks. They're parallel and there are two different nerves that go down the same nerve, but they also connect like a ladder. So what I'm doing right there, because I noticed that I was palpating from north to south or S to I, is I was feeling the nerve that was being stuck along one of the ladder rungs instead. So it's important to check all of the areas where a nerve can be entrapped, because a nerve can be entrapped anywhere. An irritated nerve is not an adhesed nerve. An adhesed nerve, the nerve will generally be healthy and a small diameter, and there will be a fascial glue somewhere near it. Irritated nerve will typically be either swollen, or when you push on it, it will cause the muscles to contract and to pop you off, different than what adhesion will feel like. It's not coming from there. Lie face down, Guatham. So he feels the butt pain at his sciatic nerve, but it's not coming from here because there's no adhesion. So it's partially coming from here, and then I'm just gonna check this right now really quickly. This one usually feels really good. Go, James. Breathe, Guatham. Yeah. Good. You feel how this is better now?
Yeah.
So this is softer because I just released the sciatic nerve there.
Okay.
It's proximal sciatic nerve at medial adductor magnus. Coming up, my friend.